Welcome, curious minds, to another deep dive. Imagine this. You've just landed your first attending gig fresh out of surgical pathology fellowship.
Yeah.
The coffee's brewing, your microscope is beckoning, and then, that first complex soft tissue or bone tumor case lands on your desk.
Mm-hmm.
Suddenly you're on the hot seat.
Yeah.
The stakes are incredibly high, right? Not just for your confidence, but for the patient's entire treatment path. Making that right call, it's absolutely critical.
That's a feeling every pathologist knows well, I think. Especially with mesenchymal neoplasms, the nuances in this field can be, well, daunting.
Definitely.
So we've designed this deep dive specifically for you, our new attending surgical pathologist, as a kind of high-yield board review.
Right.
Our mission today is to equip you with the essential immunohistochemical, or IHC, knowledge you need to confidently navigate independent sign-out for these challenging cases.
That's exactly it. Our goal isn't just to, list markers. We're going to unpack the practical application, delve into the subtle nuances, highlight the common pitfalls, and perhaps most importantly, reveal the why behind what you see under the microscope.
Yeah.
Think of this as your personal distilled cheat sheet, packed with actionable insights from comprehensive literature on IHC and bone and soft tissue neoplasms, ready for those moments when you're truly on your own.
Exactly. We've built a robust framework looking at both established and emerging markers. We're going to extract those crucial nuggets of knowledge that offer immediate clinical utility and really help you build that multi-layered diagnostic picture. Ready to jump in?
Absolutely. Let's start by laying down what we call the foundational pillars in Section 1, beginning with intermediate filaments and those core epithelial markers.
Okay. So the first and truly foundational principle to engrave in your mind is that IHC is always an adjunct.
All right.
It's a supplementary tool to thorough histologic evaluation, never, ever a replacement. Morphological assessment, that's still king.
Yeah.
If the histology isn't guiding you, just throwing a battery of stains won't magically reveal the answer. In fact, it can sometimes lead you down the wrong path.
Oh, I've definitely seen that happen. It's like having all the pieces of a puzzle, but you're trying to force them together without looking at the picture on the box. Yeah.
That's a perfect analogy.
So beyond morphology, what other essential pieces do we need to consider when approaching these complex lesions?
You've hit on a crucial point there. For many soft tissue and bone lesions, clinical presentation and radiologic correlation are absolutely integral. You can't ignore those. And increasingly, molecular studies play a significant and often definitive role. So it's about building a comprehensive, multi-layered diagnostic picture where IHC steps in to confirm or refine a morphologic impression, or maybe to guide those further molecular studies when morphology alone remains ambiguous. IHC helps you clarify, but it doesn't stand alone.
Okay, let's talk about intermediate filament proteins, or IFPs. They're often described as the cell's internal scaffold. But I recall learning they're far more dynamic than just simple building blocks, aren't they?
They are.
They even serve as, cellular communicators. What's the diagnostic aha moment we should be thinking about here?
You're right to highlight their dynamism. IFPs are fundamental structural components, typically 7 to 10 nanometers in diameter, arranged in skeins or bundles within the cytoplasm. While they do maintain cellular ship and anchor internal components, our understanding has evolved significantly.
Right.
We now know they're involved in things like nucleic acid binding and can modulate cell processes responding to extracellular signals. For us as pathologists at the scope, the key insight is that despite their underlying biochemical similarities, it's their characteristic distribution patterns in both non-neoplastic cells and tumors that makes them diagnostically useful. They tell a story about a cell's lineage, even with their dynamic nature. We primarily focus on 5 moieties for diagnostic pathology: keratins, vimentin, desmin, and neurofilament proteins, NFPs, and glial fibrillary acidic protein, GFAP.
Fascinating how something so fundamental can offer such specific clues. Now let's move to keratins. These are the quintessential epithelial signature, right? Yet this is where we encounter those surprising sarcomatous exceptions that can really trip up a new pathologist.
Indeed. Keratins are the essential IFPs of epithelial cells and carcinomas, offering high specificity and sensitivity for carcinoma diagnosis among malignant tumors. They typically express in acidic, or type I, and basic, or type 2, pairs. The presence of keratin generally points strongly to an epithelial origin.
Okay, but here's where it gets really interesting, because that rule, as strong as it is, has some critical exceptions in mesenchymal tumors. What are the key tumors that regularly throw this curveball, expressing keratins despite their sarcomatous nature? This is a diagnostic pitfall that can lead to a complete misdiagnosis, right?
This is a crucial point, absolutely, and it challenges our most fundamental assumptions about lineage sometimes. For example, synovial sarcoma can express multiple keratin types, including CK1, 7, 8, 13, 14, 18, and 19.
Wow.
Epithelioid sarcoma frequently shows CK8, 18, and 19 reactivity. Chordoma often expresses CK8, 18, 19, and sometimes CK4 and 5. Myoepithelioma and myoepithelial carcinoma, which used to be called perichordomas, can also express CK8. And adamentinoma regularly shows CK5 and 19. The biological why behind this isn't fully elucidated for all, but for tumors like synovial sarcoma, it reflects their often biphasic nature, with a true epithelial component that drives this reactivity.
Right, that makes sense for biphasic.
But the surprises don't stop there. Nearly all sarcomas have the potential for aberrant keratin synthesis. It's not impossible.
Really? All of them?
Well, the potential is there. However, it's most commonly seen in a narrow spectrum of malignant mesenchymal tumors, principally leiomyosarcoma, angiosarcoma, especially those epithelioid variants, and to a lesser degree, Ewing sarcoma and alveolar rhabdomyosarcoma.
Okay.
In these, CK8, 18, and 19 are most often observed. The takeaway: don't let a positive keratin stain prematurely close your mind to a mesenchymal diagnosis. You have to keep that possibility open.
That's a vital warning. And what about instances where the aberrant expression might not even be biological, but maybe a technical artifact? How do we avoid those traps?
An excellent question. Aberrant IFP expression can absolutely be due to technical flaws. This could be, say, inappropriately high antibody concentration or maybe overly sensitive detection procedures. Since IFPs are structurally related, cross-labeling with Vimentin, Desmin, NFPs, or GFA can spuriously occur. The practical solution is not to chase every faint stain.
Right.
Instead, maintain appropriate immunodetection windows to minimize overlap and maximize diagnostic utility, especially with formalin fixed paraffin-embedded material. This careful approach lowers the incidence of misleading aberrant keratin expression. Remember, a weak, patchy stain that doesn't fit the morphology is often just a red herring.
That makes perfect sense. Now, let's pivot to Vimentin. It's often introduced as the mesenchymal marker, but in practice, its utility seems rather limited, doesn't it?
It really does.
What's the practical implication of its ubiquity?
You're spot on. Vimentin, a 57-KOD protein, is present in most fetal cells early in development. Here's the key. When 2 or more IFPs are co-expressed by a cell line or neoplasm, Vimentin is almost always one of them.
Always.
Its ubiquity in soft tissues severely limits its diagnostic use for identifying specific mesenchymal lineages. It's so widespread that a positive Vimentin stain on its own tells you very little about the specific type of mesenchymal tumor you're looking at.
So if its diagnostic utility is so limited, how do we use it in a panel? What does it actually tell us then?
Primarily, it serves as a useful internal control for tissue preservation and processing.
Ah, okay, the control.
Exactly. If Vimentin isn't easily detected in non-neoplastic mesenchymal elements like endothelial cells or fibroblasts, which are routinely present in almost any tissue section, then you can't properly trust the reactivity or maybe the non-reactivity of your neoplastic cells.
Right.
It's your quality control check. If your Vimentin isn't working, your other stains might not be either, or at least you can't be sure.
Got it. Are there any unique scenarios where Vimentin's expression is distinctive and genuinely helpful? Give us an example that sticks.
Occasionally, yes. Its expression pattern can be quite unique. For example, in malignant rhabdoid tumors, Vimentin typically forms a dense globular cytoplasmic configuration that actually indents the nuclei of the neoplastic cells.
Oh, interesting.
That peculiar, almost squash nucleus look, thanks to Vimentin, is quite memorable and diagnostically helpful in that specific aggressive tumor.
Okay, I'll remember that one. Moving from these general scaffolds to specific muscle signals, let's discuss Desmin. What's its role, and how does it differentiate itself from Vimentin in terms of diagnostic power?
Right, Desmin. It's a cytoplasmic IFP characteristically found in muscle cells and in neoplasms with myogenic differentiation. It's a 53-kilod protein playing a key role in binding myofilaments into bundles and anchoring the contractile apparatus to the cell membrane. Crucially, it itself does not participate in contractility.
Okay.
It appears in developing striated muscle, actually replacing Vimentin at the myotube forming stage. The diagnostic power of Desmin lies in its specificity. It's detected in almost all rhabdomyosarcomas and leiomyosarcomas.
Almost all, yeah.
While not all muscle cells contain Desmin, for instance, mammalian aortic smooth muscle is typically negative, its consistent presence points strongly to myogenic differentiation. Desmin expression may also be seen in myofibroblastic tumors and tumors of uncertain lineage, like desmoplastic small round cell tumor, where its positivity is a key component of a pretty complex immunoprofile.
Gotcha. Next up, neurofilament proteins, or NFPs, and glial fibrillary acidic protein, GFAP, providing clues from the nerve and glial worlds. Given their names, one might assume broad utility in neural tumors, but what's their real practical application in soft tissue and bone pathology? Is it limited?
It is somewhat limited compared to their CNS roles, yes. NFTs are larger, composed of 3 subunits, 68, 150, and 200 kilod's. Their expression correlates with differentiation into committed neurons, and their phosphorylation status in vivo can affect antibody specificity, which is a subtle but important technical point for us. Primarily, NFPs are seen in neuroblastoma and other neurogenic tumors. As for GFAP, a 51 QOD protein and the major component of astrocytes and ependymal cells, its role in soft tissue tumors is more limited. However, it can be expected in selected neoplasms that include Schwann cells, myoepithelial cells, or chondrocytes.
Okay.
This means it may serve as a second-line marker for malignant peripheral nerve sheath tumor, or MPNST, though it shows only focal labeling in, at most, 30% of cases.
Only 30%.
Yeah, not great sensitivity there. It's also present in up to 50% of myoepithelial tumors and can be found in Schwann cells and chondrocytes. So think of GFEP as more of a supporting actor, not a lead, in most soft tissue differentials.
All right, that brings us nicely to section 2. Beyond the basics, expanding the epithelial, muscle, and neural repertoire. We've covered the foundational IFPs. Now let's expand our toolkit and delve into more specific markers that really help us fine-tune our diagnoses in complex cases, starting with epithelial membrane antigen, EMA. It sounds like it's more versatile than just being strictly epithelial.
It definitely is. EMA, also known as HMFGPs, is packaged in the Golgi apparatus, which often results in a characteristic globular labeling pattern immunohistochemically. While abundant in non-neoplastic epithelial cells, it's also found in various non-epithelial cells like perineurial cells, plasma cells, arachnoid cells, ependyma, and choroid plexus.
So if it's not exclusively epithelial, what's the crucial diagnostic rule we need to remember for mesenchymal tumors? What makes EMA truly meaningful for epithelial differentiation versus just being, background noise or something spurious?
The crucial diagnostic nugget here is that true EMA reactivity, the kind that genuinely equates with epithelial differentiation, must be localized to the cell membrane. Purely cytoplasmic labeling without a distinct membrane component is considered a spurious pattern and should generally be ignored for diagnostic purposes. This distinction is critical because numerous mesenchymal neoplasms can be EMA immunoreactive. These include synovial sarcoma, epithelioid sarcoma, low-grade fibromyxoid sarcoma, LGFMS, perineuriomas, angiomatoid fibrous histiocytoma, AFH, epithelioid fibrous histiocytoma, chordoma, and myoepithelial carcinoma.
Wow.
So for EMA, it's really all about the pattern of staining. Crisp membrane staining matters.
That's a lot of potential overlap. When standard epithelial markers like keratin and EMA yield ambiguous results, what about other, perhaps more nuanced epithelial markers like tight junctions and adhesion molecules? Do they offer more precision, maybe?
They can be useful adjunctive tools, especially in challenging cases, yeah. Claudin-4, for instance, is a tight junction-associated protein expressed by most epithelial cells, but rarely in mesenchymal or mesothelial cells. This makes it particularly helpful in differentiating carcinoma from sarcoma or mesothelioma, typically showing a strong, diffuse, membranous pattern in carcinoma. Consistent with its epithelial differentiation, the biphasic component of synovial sarcoma will express Claudin-4, and it's also seen in a small subset of myoepithelial carcinomas.
An older adhesion molecule like desmoplakin, desmoglein, E-cadherin, and N-cadherin. What's their specific utility here? Are they still used much?
They're perhaps less commonly used now, but still have a role. Desmoplakin and desmoglein are elements of desmosomal complexes, those specialized intercellular anchoring structures. Cadherins are calcium-dependent transmembrane intercellular adhesion molecules vital for cell-to-cell adhesion.
Right.
E-cadherin is typically associated with epithelial differentiation, contributing to strong cell-cell junctions. While there are exceptions, concurrent reactivity for desmoplakin or desmoglein and E-cadherin is generally restricted to epithelial neoplasms and mesenchymal tumors with epithelial characteristics, like synovial sarcoma, which has true epithelial differentiation. In one large study, E-cadherin was found in 100% of biphasic synovial sarcomas, 50% of monophasic synovial sarcomas, and only 8% of epithelioid sarcomas. N-cadherin expression was present in 100% of chordomas, 86% of biphasic synovial sarcomas, and 38% of epithelioid sarcomas. These markers confirm that certain mesenchymal tumors truly mimic epithelial differentiation at a fundamental level.
Let's delve deeper into muscle markers now. Beyond Desmond, which tells us muscle, what nuances should we be aware of with alpha-smooth muscle actin or SMA and muscle-specific actins like HHF35? How do we pick the right one or use them together?
That's a great question about precision. Alpha-smooth muscle actin, aka, is widely expressed not only in smooth muscle but also in myofibroblasts and parasites.
Right, myofibroblasts too.
Exactly. This ubiquity means it's less specific for pure myogenic differentiation than markers like apaldisman or HHF35. If you see ATHM alone, you're looking at a broader category. HHF35, on the other hand, shows more muscle-restricted immunoreactivity in routinely processed specimens, expressed in both smooth and skeletal muscle. You'll find it positive in rhabdomyosarcoma, leiomyosarcoma, and benign muscle tumors, while myofibroblastic tumors like nodular fasciitis show variable reactivity. So HHF35 gives you a stronger, more restricted muscle signal compared to SMA.
And what about Culdesman and Calponin? How do they fit into this muscular puzzle? Where do they help differentiate?
H-Culdesman is a cytoplasmic protein that appears to be relatively specific for smooth muscle differentiation.
Smooth muscle, huh?
It's a useful adjunct to desmin and actin immunostains in evaluating leiomyoma and leiomyosarcoma. The vast majority of leiomyomas are positive, but expression in leiomyosarcoma is more variable, unfortunately. It's not entirely specific, though, as reactivity is also observed in most gastrointestinal stromal tumors, GI cysts, glomus tumors, and some myoparasitomas, a crucial differentiator. Myofibroblastic cells do not express caldemin, so if you're trying to rule out a myofibroblastic lesion in favor of smooth muscle, Culdesman can be very helpful.
That's a key point.
Yes. Calponin, an actin-binding protein, is expressed in smooth muscle, myoepithelial cells, and myofibroblasts. So it's broader than Culdesman. Reactivity is seen in leiomyoma, leiomyosarcoma, nodular fasciitis, other myofibroblastic tumors, and myoepithelial neoplasms. GIST, notably, tends to be negative for calponin, giving it a differential role there.
Shifting to more specific skeletal muscle markers now, myoglobin, MYOD1, and myogenin are crucial. I know myoglobin used to be a go-to, but its limitations seem to have paved the way for MYOD1 and myogenin. What's the practical difference in their roles and why are the latter so much more powerful, really?
You're right to highlight that shift. Myoglobin, a 17.8 kilod protein, is exclusively found in skeletal muscle where it transports oxygen. However, it appears relatively late in muscle maturation, making it often undetectable in embryonal neoplasms.
Right, the ones we need to diagnose.
Exactly, the very rhabdomyosarcomas we often diagnose. This, coupled with background staining issues with older polyclonal antibodies, severely limits its clinical utility. You're trying to catch the fish when it's just a tiny fry, and myoglobin can only see the adult, so to speak.
Yeah.
In stark contrast, MYOD1, a 46 kilod protein, and myogenin, a 32 kilod protein, are nuclear transcription factors that are highly specific for striated muscle differentiation. They are the master regulators, activating their own transcription and governing the initiation of striated muscle differentiation.
Okay.
They're expressed by fetal and regenerating skeletal muscle cells, but not by normal adult skeletal muscle, making them excellent early indicators of primitive muscle differentiation.
What are the practical considerations and potential pitfalls when using MYOD1 and myogenin? Because strictly nuclear sounds like it has to be perfect. You have to be careful interpreting that.
It's absolutely critical to remember that MYOD1 and myogenin are strictly localized to cellular nuclei. Any background cytoplasmic labeling, which can be a problem with some MYOD1 antibodies, must be ignored as a spurious pattern. It's like looking at static on a screen. Myogenin stains generally don't show this issue as much.
Okay.
Unlike myoglobin, expression of MYOD1 and myogenin is greatest in less differentiated rhabdomyosarcoma, with the alveolar subtype showing the most extensive expression, followed by embryonal. Pleomorphic rhabdomyosarcoma typically shows less expression. Spindle cell sclerosing RMS often shows more extensive expression of MYOD1 than myogenin due to the presence of MYOD1 mutations in many cases. While their specificity for skeletal muscle differentiation is high, extreme care should be taken when interpreting these immunostains, as positivity limited to reactive skeletal muscle cells within a biopsy, trapped muscle.
Oh, right. Big pitfall.
Huge pitfall. That can lead to an erroneous diagnosis of rhabdomyosarcoma. Always look for the tumor cells themselves expressing and not just background muscle.
Now, let's dive into nerve sheath markers. S100 protein is famously versatile, but its very ubiquity can be a challenge. How do you decide, practically, when it's genuinely helpful versus just background noise? It's one of those stains that can almost be too positive, isn't it?
That's an excellent point, and it speaks to the art of using S100 effectively. It's a dimeric calcium flux regulator with wide distribution in human tissues. Collia, neurons, chondrocytes, Schwann cells, melanocytes, myoepithelial cells. The list goes on.
Wow.
Its wide distribution means it's definitely not specific enough on its own to define a lineage.
Right.
Its diagnostic utility truly comes into play when used within a panel and in the proper context. S100 is a valuable indicator of Schwannian or melanocytic differentiation. It's usually nuclear and cytoplasmic. For example, it's found in over 90% of clear cell sarcomas of tendons and aponeurases, diffusely and strongly positive in schwannomas, and variably reactive in neurofibromas, maybe 50–80% of constituent cells. However, its expression in MPNST is usually limited, often focal, maybe 30–50% of cases. It's also seen in ossifying fibromyxoid tumor, extraskeletal myxoid chondrosarcoma, sometimes synovial sarcoma, and approximately 5–10% of GS.
So quite a range.
It is. Among bone tumors, S100 is consistently detected in well-differentiated cartilaginous neoplasms and in up to 80% of chordomas. So practically, if a tumor that isn't typically S100 positive shows only weak, patchy staining, especially in a mixed inflammatory background, it's often more likely to be nonspecific background or reactive cells rather than genuinely helpful. You need to correlate strong, consistent S100 with morphology and the rest of your panel to trust it.
That brings us to SOX10. How does this neural crest transcription factor compare to S100, and is it a better alternative sometimes for nerve sheath tumors? More specific, maybe.
It often is more specific, yes. SOX10 is a neural crest transcription factor, critical for Schwann cell and melanocyte differentiation, showing nuclear staining in normal melanocytes, Schwann cells, myoepithelial cells, and salivary gland acinar cells. It shows similar sensitivity to S100 protein for MPNST, with nuclear expression in 30–50% of cases.
Okay.
However, the majority of benign nerve sheath tumors and over 90% of melanocytic neoplasms, including clear cell sarcoma, express SOX10. Where SOX10 truly shines and often becomes more helpful than S100 is its limited expression in other mesenchymal and epithelial tumors.
Ah, that's the key.
That higher specificity makes it particularly useful for confirming melanocytic differentiation, especially in cases of metastatic melanoma with limited or no S100 protein expression, or differentiating nerve sheath tumors from other spindle cell lesions that might be weakly S100 positive.
What about CD56 and CD57? Are these still considered useful for nerve sheath tumors in modern practice? Or have they fallen out of favor?
Mostly fallen out of favor, I'd say. CD56 and CD57 are membrane antigens that react with several neural molecules. However, they are not restricted to nerve sheath cells or neuroectodermal elements among soft tissue tumors. They can also be observed in synovial sarcoma, leiomyosarcoma, and some metastatic carcinomas.
Right.
Because of this broad expression and lack of specificity, we, as pathologists, generally do not use these markers in routine clinical practice for diagnosing soft tissue tumors. They simply don't provide the precision needed for complex differentials and can be more misleading than helpful, frankly.
And finally, for this section, collagen type IV and laminin.
Okay.
What's their role? I usually think of them in basement membranes, structural components.
You're right. They are predominant components of basement membranes. Collagen type IV is a triple helical molecule that doesn't form fibrils like other collagen types. Laminin is a large molecule that binds to glycosaminoglycans, acting as a bridge for the attachment of collagen type IV to the surrounding matrix. Beyond simple boundary and anchoring functions, laminin also influences intracellular interactions and contributes to alterations in cellular morphology. While they contribute to our understanding of the tumor microenvironment, their primary diagnostic utility in soft tissue and bone tumors often involves quantitative assessment by IHC to evaluate the integrity or development of basement membranes, such as the paracellular staining seen in certain nerve sheath tumors, rather than as specific lineage markers themselves. They help us understand the context of the tumor cells, how they're interacting with their surroundings.
Okay, interesting. Now we're moving into section 3. endothelial markers from general to highly specific. Historically, factor VIII-related antigen, or von Willebrand factor, was quite prominent, wasn't it? You used to see it ordered all the time.
It absolutely was a workhorse back in the day. Factor VIII-related antigen, or VWF, is a very large polymeric protein synthesized exclusively by endothelial cells and megakaryocytes. Physiologically, it forms circulating complexes with factor VIII coagulant protein and plays a crucial role in platelet aggregation. It was one of the earliest markers used for vascular tumors, but its limitations, mainly lower sensitivity and specificity compared to newer markers, and often difficult background staining, paved the way for more refined endothelial markers. It's largely been superseded in routine practice now.
Which brings us to CD34, often considered a broad-brush endothelial marker. But it pops up in so many other places, as we touched on earlier. What's the biggest diagnostic challenge with it? Why is it so tricky?
The biggest challenge with CD34 is precisely its lack of specificity. It's a 110 kilodalton transmembrane glycoprotein expressed by embryonic hematopoietic cells and endothelial cells. It's relatively sensitive for endothelial lineage, recognizing over 85% of angiosarcomas and Kaposi sarcomas. However, its specificity is low, making it a tricky marker to interpret in isolation.
That low specificity can be a real landmine then. What are some of the key non-endothelial tumors that can express CD34, making it a broad brush rather than a precise tool on its own? This is where pathologists can get into trouble, right?
You're right, it's a common track. CD34 expression is commonly seen in dermatofibrosarcoma protuberans, or DFSP, where diffuse CD34 is characteristic and helps distinguish it from benign fibrous histiocytoma. However, it's often lost during fibrosarcomatous transformation of DFSP. It's also frequently positive in spindle cell lipoma and gastrointestinal stromal tumors, or GISTs, about 70–90% of spindle cell gisteists, and up to 50% of epitheliogists.
Wow, GISTs too.
Yes. Solitary fibrous tumor, or SFT, is another consistent CD34 positive entity. We also see it in some leiomyosarcomas, particularly retroperitoneal ones, maybe 20–30% of cases. Peripheral nerve sheath tumors, about 50% of epithelioid and 65% of perineuromas. So while it indicates a mesenchymal lineage and can be useful in a panel, if you're seeing CD34 and thinking endothelial, you absolutely need other specific markers to confirm that, or you'll misdiagnose.
That's a comprehensive list of potential mimics. So when we want something more restricted, something truly indicative of endothelial differentiation, we turn to CD31, also known as PCAM1.
Yep.
How much more reliable is it? Is it the go-to after CD34?
CD31 is indeed a significant step up in specificity. It's a 130 kilodalton transmembrane glycoprotein expressed by endothelial cells, megakaryocytes, platelets, and histiocytes. In soft tissue tumors, CD31 is highly restricted to endothelial neoplasms, consistently showing a membranous pattern of staining.
Membranous. Right.
Its sensitivity is excellent, with over 90% of angiosarcomas being CD31 positive, regardless of morphologic grade or subtype. It's also consistently detected in hemangiomas and various hemangioendothelioma variants. However, Kaposi sarcoma tends to stain more consistently for CD34 than CD31, which is an interesting point.
What's the biggest pitfall with CD31 then? If it's so much more restricted, is there still a trap waiting for us?
The greatest pitfall in interpreting CD31 expression is its positivity in macrophages, or histiocytes.
The background cells again.
Exactly. These can be present in large numbers, dispersed among tumor cells, leading to misinterpretation of a vascular tumor when it's just reactive histiocyte staining. Not surprisingly, CD31 expression is also seen in histiocytic sarcomas. Less commonly, focal CD31 expression can occasionally be found in otherwise undifferentiated pleomorphic sarcomas and very rarely in carcinomas and mesotheliomas. So always make sure the positivity is in the neoplastic cells and not just the inflammatory background or trapped macrophages.
Good advice. Next, FLI1, a nuclear factor. I know it's famously associated with Ewing sarcoma, but I hear its specificity is quite limited, as you mentioned. Why did it ultimately disappoint as a reliable marker for either Ewing or vascular tumors?
Right. FLI1, or Friend leukemia virus integration 1, is an ETS family transcription factor, 98 amino acids long, that shows nuclear expression. It's involved in cell proliferation and the development of hematopoietic precursors in endothelial cells, and is normally expressed in the nuclei of lymphocytes and endothelial cells. Its association with the EWSR1 gene in most Ewing sarcomas made it initially promising. FLI1 positivity has also been found in melanoma, synovial sarcoma, Merkel cell carcinoma, and lung adenocarcinoma. The initial studies showed high sensitivity for endothelial neoplasms up to 94%, but that quickly unraveled. Subsequent studies documented FLI1 positivity in some carcinomas, lymphomas, rhabdomyosarcomas, squamous cell carcinomas, atypical fibroxantomous melanomas, and atypical intradermal smooth muscle neoplasms, just all over the place.
Yes, right.
The reason it disappointed is that while it participates in gene fusions, the protein itself is a general transcription factor that can be upregulated or expressed in many disparate tumor types, regardless of its specific fusion. Its promiscuous expression simply does not support its use as an adjuvant for diagnosing either Ewing sarcoma or vascular neoplasms due to its poor specificity. It's a classic example of marker that, while biologically important, just isn't precise enough for routine diagnostic use.
That brings us to ERG, which truly sounds like the current gold standard for endothelial differentiation.
Yeah.
What makes it so superior to the others? Why is it the one everyone reaches for now?
ERG, or VE26 transformation-specific avian erythroblastosis virus E26 oncogene homolog, is another ETS family transcription factor. It's expressed in a nuclear pattern in primitive mesenchymal cells, and then becomes very specifically limited to vascular endothelium and a subset of normal hematopoietic stem cells and immature myeloid cells. A rabbit anti-ERG monoclonal antibody is commercially available and is, indeed, considered a highly sensitive and specific marker of endothelial differentiation.
How does it perform as an internal control? And how broadly can we trust it in actual tumors? Is it consistently positive?
ERG is ubiquitously expressed in the nuclei of normal endothelium, which serves as an excellent internal control for your stain. If you see normal vessels staining nicely, your ERG is working.
That's handy.
Very. Nuclear expression of ERG has been reported in 100% of hemangiomas, 98% of epithelioid hemangioendotheliomas, EHEs, and 96% of angiosarcomas. It consistently shows strong and diffuse staining regardless of morphologic differentiation. In fact, all cutaneous angiosarcomas expressed ERG in 2 large studies. This makes ERG significantly more sensitive and specific for vascular tumors than CD31, CD34, and FLI1 combined. It's truly been a game changer for identifying endothelial differentiation reliably.
Are there any pitfalls, though? Even with such a strong marker, any known traps for us with ERG?
There are a few, and they're important to know. Approximately 5% to 10% of Ewing sarcomas show ERG expression, specifically those with the YWSR1 ERG fusion gene.
Right, the fusion partner.
Exactly. Variable staining for ERG can occur in epithelioid sarcoma. N-terminus antibodies show expression in up to 68% of cases, while C-terminus antibodies result in less than 5% expression. This can be a potential pitfall in the differential diagnosis with ERG. However, the loss of INI1 expression in epithelioid sarcoma usually helps to resolve this, as AHE retains INI1. ERG expression has also been described in various cartilaginous tumors and approximately 50% of prostatic adenocarcinomas due to the TMPRSS2 ERG fusion gene, though ERG is not expressed by normal prostatic epithelium. It is very rarely seen in other epithelial neoplasms, and notably, cytoplasmic ERG staining in non-endothelial tumors has not been observed in our practice, meaning nuclear ERG is the key finding to look for.
That's incredibly helpful for refining the differential.
Yeah.
What about lymphatic endothelial markers, taking us beyond just blood vessels? Do we have specific tools for those, or is it still a challenge?
It's still a bit of a challenge for specificity. For lymphatic endothelium, potoplanin, recognized by the antibody D240, is a selective marker for lymphatic channels. It's expressed in lymphatic endothelium, mesothelium, various epithelia, follicular dendritic cells, and germ cells. In soft tissue neoplasia, it can be used to determine lymphatic differentiation in vascular neoplasms and is found in a subset of angiosarcomas, caposiform hemangioendothelioma, and Kaposi sarcoma, which may reflect lymphatic differentiation. However, its utility is somewhat limited by its general lack of specificity, as many other tumor types can also be positive. So it's best used perhaps to delineate lymphatic invasion by carcinomas and melanomas, not as a sole diagnostic marker for a lymphatic tumor itself.
Okay.
VEGFR3, or FLT4, is another transmembrane protein initially thought to be predominantly expressed in lymphatic endothelia. It's found in over 90% of Kaposi sarcoma, papillary intralymphatic angioendothelioma, DAPSCA tumor, and retiform and caposiform hemangioendotheliomas, 50% of angiosarcomas and 15% of hemangiomas. However, it's also expressed by non-neoplastic capillaries and in some carcinomas and sarcomas, again limiting its specificity.
Are PROX1, Claudin-5 GLOT1, or Ulix europaeoside agglutinin still useful in practice for lymphatic differentiation? Or have they mostly been phased out due to lack of specificity, like you said?
For practical purposes, their utility is quite limited now. PROX1, a nuclear transcription factor for lymphatic development, has limited utility due to a lack of specificity and sensitivity, despite being expressed in 58% of vascular tumors and also in Ewing sarcoma, paragangliomas, synovial sarcomas, and various carcinomas. It might suggest lymphatic differentiation, but it's certainly not definitive.
Right.
Claudin-5, a transmembrane tight junction protein, is sensitive for detecting endothelial differentiation, but it is also nonspecific, as it's expressed in many different epithelial tumors. And as for GLUT1 and Eulex europaeus I-agglutinin, or UEAI, their clinical utility is minimal due to low specificity. GLUT1 is present in juvenile capillary hemangiomas, but also in many solid tumors. UEAI, a lectin, binds to endothelial cells, but also to epithelioid sarcoma and various metastatic carcinomas. These are largely historical or niche markers now, and you'll rarely reach for them in a complex differential today.
Okay, good to know which ones to sideline. Section 4. Histiocytic and melanocytic markers, navigating the pigmented and inflammatory mimics. This is a tricky area because these can often look like other things, right? Especially with a heavy inflammatory infiltrate obscuring the picture.
Oh, absolutely.
Let's start with the broad histiocytic spectrum. What makes general markers like CD68 so non-specific here? Why can't we just rely on that?
You're right, it's incredibly tricky. The histiocytic spectrum is indeed challenging due to frequent nonspecificity of many traditional markers. General markers like CD68, alpha-1 antitrypsin, alpha-1 antichymotrypsin, myromidase lysozyme, cathepsin B, and HM56 often show positivity in any lysosomal-rich cell.
Any cell?
Yeah. CD68, 110 kD lysosomal protein, is frequently found in tumor-infiltrating histiocytes. Macrophages are everywhere in tumors. This requires careful interpretation to avoid over-interpreting positive staining in background cells as tumor cells. It can also be seen in granular cell tumors, schwannomas, renal cell carcinomas, and melanomas, further limiting its specificity. So if you see CD68 alone, it's almost meaningless for a specific histiocytic tumor diagnosis. It just tells you there are probably macrophages around.
So if CD68 isn't specific enough for primary histiocytic tumors,
Yeah.
what's our go-to? What marker gives us the most confidence in identifying true histiocytic lineage, separating tumor from background?
CD163 is currently considered the most specific histiocytic marker for monocytomacrophage lineage.
CD163.
It's a glycoprotein belonging to a scavenger receptor superfamily and primarily shows a membranous staining pattern. CD163 expression is reliably found in the majority of cases of Rosai-Dorfman disease, histiocytic sarcoma, hemophagocytic lymphohistiocytosis, tenosynovial giant cell tumor, and a subset of Langerhans cell histiocytosis, as well as some acute myeloid leukemias with monocytic differentiation. Critically, its expression in other soft tissue tumors is extremely limited, and epithelial tissues and tumors are typically negative. This makes it far more reliable than CD68 for true neoplastic histiocytic differentiation. It's your current best friend for identifying a genuine histiocytic proliferation.
And what about lysozyme, factor XIII, and NKIC3? Do they still have a place, maybe in specific scenarios?
They have niche uses, perhaps. Lysozyme, a bacteriolytic enzyme present in granulocytes and histiocytes, can show cytoplasmic expression in pure histiocytic lesions like juvenile xanthogranuloma and histiocytic sarcoma. But fibrohistiocytic tumors like benign fibrous histiocytoma are typically negative. Factor XIII, involved in fibrin polymerization, has limited diagnostic utility because staining in benign fibrous histiocytoma is often due to expression in background non-neoplastic dermal cells rather than the tumor cells themselves. NKIC3, a monoclonal antibody against a melanoma-associated antigen, has greater utility in cellular neurothekioma, but stains a wide range of histiocytoid soft tissue neoplasms and other cutaneous tumors, including juvenile xanthogranuloma, atypical fibroxanthoma, and cellular benign fibrous histiocytoma. So they have specific limited uses, but aren't frontline for general histiocytic tumors like CD163 is.
Now, on to melanocytic markers. This is another area where things can get confusing, especially when we're dealing with non-pigmented variants that don't have that obvious melanin to guide us.
Okay.
How do we pinpoint them with IHC when they look like something else?
Exactly. For melanocytic differentiation, HMB45 is a highly specific marker. It works by recognizing a pre-melanosomal protein, which means it picks up melanocytic lineage even before visible pigment is formed.
Ah, pre-melanosomal. Good point.
Yes, it's particularly useful for identifying neoplasms of the Pacoma family, which exhibit that dual myeloid and melanocytic differentiation. HMB45 is also expressed in clear cell sarcoma of pendens and aponeuroses, often with stronger intensity than S100 protein, and a malignant melanotic nerve sheath tumor. Its expression appears quite limited to these specific tumor types, making it very reliable when positive.
And melon A, how does that compare?
Melon A, also known as ARM-ART1, shows cytoplasmic expression in normal melanocytes and, importantly, adrenal cortical cells. Similar to HMB45, it's frequently seen in picomas. While it's found in approximately 80% of metastatic melanomas, it's notably negative in desmoplastic melanomas, which is a key point.
Right.
However, melon A is less specific than HMB45, as it can also be expressed by tumors of the adrenal cortex and ovarian and testicular Leydig cell tumors, particularly with the A103 clone. So, while highly useful, it's got a slightly broader range than HMB45, and you need to be aware of those non-melanoma positives.
And what about MITF and tyrosinase? Are they still in our go-to melanocytic panel, or are they less useful?
MITF, or microphthalmia-associated transcription factor, is a nuclear protein and transcriptional regulator of melanocytic genes. However, its clinical utility in surgical pathology is limited by its low specificity, as nuclear expression is seen not only in melanocytes and melanomas, but also in some sarcomas, clear cell sarcomas, and histiocytic proliferations. It's just too broad for confident lineage assignment on its own.
Okay.
Tyrosinase, a 75 kD glycoprotein, catalyzes the incorporation of tyrosine into melanin pigment. Its use in soft tissue pathology is mostly limited to melanoma identification, with over 90% of metastatic melanomas showing diffuse cytoplasmic staining. About 40% of clear cell sarcomas express tyrosinase, but unlike melon A and HMB45, it's not frequently seen in sarcomas. So think of tyrosinase as confirming active melanin synthesis, not just melanocytic lineage. It tells you the machinery is working.
Got it. Shifting gears now to Section 5, Unique Markers and Genomic Insights, the Future is Now. This is where we see the really cutting-edge stuff, markers often tied directly to specific genetic alterations. Let's kick this off with bulcatinin, or desmoid detector. Why is its nuclear localization so significant for diagnosis? What's happening there?
Patenin's nuclear localization is a key indicator reflecting mutations in the CTNNB1 gene, or in the upstream APC gene that regulates it. This protein is a critical component of both the WANT signaling pathway, which influences cell proliferation and differentiation, and cell adhesion pathways, where it links cadherins to the actin cytoskeleton.
Right.
The why behind its diagnostic power lies in its normal function. Catenin is typically found linking cells at the membrane. When genes like CTNNB1 or APC are mutated, catenin isn't properly degraded and builds up abnormally, translocating into the nucleus. This aberrant nuclear accumulation is what we detect by IHC, and it's a strong, almost unique signature for desmoid fibromatosis, telling us that a specific growth-promoting signaling pathway has gone awry within the cell nucleus itself.
So how useful is nuclear vodkinin in practical diagnosis, considering it's not absolutely 100% specific? Is it reliable enough?
It's diagnostically very useful, but as you highlighted, it's supportive, not diagnostic on its own for desmoid fibromatosis. Nuclear vodkinin expression is present in up to 80% of sporadic desmoid fibromatosis cases and 67% of FAP-associated desmoid tumors.
Okay.
It's also seen in Gardner fibroma, about 50% of superficial fibromatosis, 30% of low-grade myofibroblastic sarcomas, and 20% of solitary fibrous tumor. Crucially, tumors like neurofibroma, schwannoma, nodular fasciitis, leiomyosarcoma, inflammatory myofibroblastic tumor, and fibroma of tendon sheath consistently lack nuclear reactivity for vodkinin.
The negatives help too.
Exactly. This negative staining can be as valuable as positive staining in the differential diagnosis, allowing you to confidently rule out important mimics.
Speaking of inflammatory myofibroblastic tumor, or IMT, what about ALK, anaplastic lymphoma kinase? That's a signature marker for them, right? What are we looking for with ALK staining, and has its detection improved over the years?
Indeed. Approximately 50% of inflammatory myofibroblastic tumors show clonal rearrangements of the ALK gene, located on chromosome 2 at band 2p23, resulting in overexpression of the ALK receptor tyrosine kinase protein, which can be detected by IHC. The fascinating part is that the pattern of ALK staining can reflect the specific fusion partner.
Oh, really?
Yes. Diffuse cytoplasmic staining occurs with fusions involving cytoplasmic proteins like TPM3 or TPM4, granular cytoplasmic staining with the CLTC fusion, and nuclear membrane staining with RNBP2, often seen in the more aggressive epithelioid IMT variant. This visual cue can even give you insight into the underlying molecular events sometimes.
Oh, that's cool. And the antibodies themselves, are they getting better, more reliable?
Absolutely. Older antibodies like ALK1 had relatively low sensitivity in paraffin-embedded sections. However, newer monoclonal antibodies, such as 5A4 and D5F3, are now commercially available and are significantly more sensitive and reliable. It's important to note that ALK expression by IHC has been reported in some cases of MPNST, leiomyosarcoma, Ewing sarcoma, and neuroblastomas, so it's not exclusive to IMT, though it is a key diagnostic signature for about half of them. A small subset of ALK-negative IMTs may show ROS1 or RET rearrangements, highlighting the ongoing need for molecular studies in some cases.
Moving to CD99, the workhorse for Ewing sarcoma, but with significant caveats. It's often the first stain we think of, but it can't be used alone. Why is that? Why the caution?
That's right. CD99, also known as MIC2 protein, is a cell surface protein that shows a diffuse membranous pattern in the vast majority of Ewing sarcomas. It's certainly a strong indicator. However, its specificity is far from absolute because it's a general cell surface protein not specifically tied to the oncogenic mechanism of Ewing sarcoma. CD99 may also be expressed, albeit often in a less distinct pattern, in T lymphoblastic lymphomas, solitary fibrous tumors, synovial sarcomas, neuroblastomas, mesenchymal chondrosarcomas, and even some high-grade neuroendocrine carcinomas. This broad overlap means that while it's a useful initial marker for Ewing sarcoma to put it on your differential, it must always be interpreted in the context of other markers and the overall clinical and morphological picture. Never, ever rely on it as a single definitive marker.
And TFE3, the marker for alveolar soft part sarcoma and some renal cell carcinomas. What's its reliability like these days? I know antibodies can change and cause issues.
TFE3, or transcription factor E3, is a nuclear transcription factor. Tumors characterized by TFE3 gene fusions, such as alveolar soft part sarcoma, ASPS, and XP11 translocation renal cell carcinoma, demonstrate nuclear TFE3 staining in almost all cases. Historically, a polyclonal antibody, P16, against the C-terminus was used, but it became notoriously less reliable over time, leading to frustrating false negatives or positives. Now, a rabbit anti-TFE3 monoclonal antibody, clone MRQ37, is available and shows far more consistent and reliable results, which is a big improvement.
Good. Any pitfalls still?
Yes. A crucial pitfall is that nuclear TFE3 expression can also be encountered in a small subset of PEComas. Therefore, caution is advised against diagnostic over-reliance on TFE3 alone, and it should always be interpreted as part of a broader panel. If you see positive TFE3, think ASPS, XP11, RCC, but keep PEComa in the back of your mind and use other markers to clarify.
Now, a true superstar marker. STAT6 for solitary fibrous tumor. But there's that intriguing connection to dedifferentiated liposarcoma that can really cause problems. What makes STAT6 such a definitive marker for SFT, and how do we navigate that potential pitfall, especially in the retroperitoneum?
Nuclear expression of STAT6 is indeed a very useful marker for solitary fibrous tumor. More than 95% of SFTs show strong, diffuse nuclear expression. This incredible sensitivity and reliability are due to recurrent NABI2 STAT6 fusion gene rearrangements, which is typically an intrachromosomal rearrangement at 12q13. This fusion leads to the overexpression of STAT6, making it an exceptionally sensitive and highly reliable marker for SFT. It really revolutionized SFT diagnosis.
But there's that significant pitfall with dedifferentiated liposarcoma, right? How do you practically tell them apart when both can be STAT6 positive, strong, and diffuse sometimes?
Precisely. This is the greatest potential pitfall when using STAT6, especially in intra-abdominal or retroperitoneal spindle cell neoplasms, where both SFT and dedifferentiated liposarcoma, or DDLPS, are primary diagnostic considerations. Well-differentiated and dedifferentiated liposarcomas can show STAT6 expression in approximately 15% of cases, and this staining can be strong and diffuse.
Okay, 15%.
Yes. This is secondary to the amplification of the 12q13 region, where STAT6 is located in close proximity to MDM2 and CDK4, which are classic markers for DDLPS. The key insight here is that the DDLPS is amplifying a whole region of the chromosome, not just a specific fusion involving STAT6.
Yeah, amplification versus fusion.
Exactly. The resolution for this differential involves looking for diffuse MDM2 and CDK4 expression, which strongly favors a diagnosis of DDLPS. If doubt persists, fluorescence in situ hybridization, or ESH, for MDM2 amplification, can definitively confirm the DDLPS diagnosis. Always think of them as a trio: STAT6, MDM2, and CDK4 for this critical differential in the retroperitoneum.
Let's discuss synovial sarcoma specificity with TLE1 and the exciting new SS18-SSX fusion-specific antibody. TLE1 was a breakthrough, but I hear its reliability has been waning, maybe less specific now. Is the new antibody truly a game changer?
TLE1, or transducin-like enhancer of SPLT1, is a transcription factor found to be significantly overexpressed in synovial sarcoma through gene profiling studies. Nuclear immunoreactivity for TLE1, usually of moderate to strong intensity, is observed in about 80% of synovial sarcomas. However, TLE1 expression is also found in approximately 15% of MPNSTs and 8% to 40% of solitary fibrous tumors, though typically with weaker staining. In recent years, the specificity of available TLE1 clones appears to be decreasing, so caution is advised, particularly when MPNST is in the differential. It's become a good screening tool, perhaps, but not definitive.
Okay.
The novel SS18-SSX fusion-specific antibody represents a significant advancement. It really is a true game changer. It is designed to recognize the breakpoint of the fusion and shows strong nuclear expression in 95% of synovial sarcomas with the SS18-SSX fusion gene. Crucially, it has not been seen in any comparison group of mesenchymal tumors.
Wow, that's specific.
Extremely. This means its sensitivity and specificity for synovial sarcoma are significantly greater than TLE1. Additionally, an antibody against the C-terminus of SSX has shown 100% sensitivity and 96% specificity. So yes, if you have access to these fusion-specific antibodies, they offer a level of diagnostic confidence for synovial sarcoma that TLE1 simply can't match anymore.
Now, a truly precise beacon for low-grade fibromyxoid sarcoma, LGFMS, and sclerosing epithelioid fibrosarcoma, SEPs, and UC4. What makes this transmembrane glycoprotein so useful for these specific, often bland-looking tumors?
MUC4, or mucin-4, is a transmembrane glycoprotein. Gene expression profiling identified its overexpression in LGFMS and CEFIFEF, giving us the why it's useful. MUC4 is an extremely sensitive marker for LGFMS, detected in virtually all cases with a strong and diffuse cytoplasmic staining pattern.
Cytoplasmic.
Similarly, extensive reactivity for MUC4 is observed in over 90% of CEF, and hybrid LGFMS-SF tumors are also positive. This consistent and diffuse positivity is what makes it so valuable for these often subtle diagnoses.
What about specificity? Are there pitfalls with MUC4?
There are. MUC4 expression is limited in most other soft tissue tumors, with only focal staining seen in a small subset of epithelioid GISTs, ossifying fibromyxoid tumors, and myoepithelial carcinomas. However, the epithelial component of biphasic synovial sarcoma frequently shows diffuse MUC4 positivity, and various carcinomas may also express MUC4.
Carcinomas too.
Yes, this is a pitfall because MUC4 is a mucin, and mucins are often expressed in epithelia. Therefore, additional keratin or lineage-specific markers are often needed to definitively exclude a carcinoma diagnosis in this context, especially metastatic carcinoma. It's a fantastic marker for LGFMSSF, but always remember its potential epithelial expression in biphasic synovial sarcoma or metastatic carcinoma.
TRK antibodies like pan-TRK are gaining prominence because they target actionable fusions. This really feels like the future's now in terms of diagnostics guiding therapy, doesn't it?
It absolutely does.
What are we looking for, and what are the limitations we need to be aware of with these?
It's very exciting. The NTRK1, NTRK2, and NTRK3 proto-oncogenes encode the tropomyosin receptor kinase proteins, TRKA, TRKB, and TRKC. Oncogenic fusions involving these genes occur in various malignancies, including infantile fibrosarcoma, often ETV6 and TRK3, sometimes LMNA and TRK1, lepofibromatosis like neural tumor, and other NTRK-rearranged spindle cell sarcomas.
Right.
Given the efficacy of TRK inhibitors in treating these tumors, pan-TRK IHC has emerged as a valuable screening tool, acting as a surrogate for detecting these rearrangements. The pan-TRK antibody recognizes TRKA, TRKB, and TRKC, typically showing cytoplasmic and/or nuclear expression. This is one of those times IHC directly leads to a specific therapeutic decision.
That's incredibly powerful.
Right.
But are there any limitations to relying solely on pan-TRK IHC for these fusions? Are we always catching them, or are there false positives, negatives?
While reported as having high sensitivity and specificity for NTRK rearrangements, recent broad studies in both pediatric and adult mesenchymal tumors have shown expression in various tumor types not expected to harbor NTRK rearrangements. This means that while highly useful for screening, pan-TRK IHC is not 100% sensitive, and rare cases with NTRK rearrangements might be missed by IHC alone. It's also not perfectly specific, so a positive pan-trick should ideally lead to further molecular confirmation like FESH or RNA sequencing, especially when targeted therapy is on the table. It's a fantastic starting point, but not always the final answer. Needs confirmation.
What about FOS and FOSB and their connections to epithelioid vascular and bone tumors? These sound like very specific mutation-driven markers as well.
They are indeed. FOS and FOSB are transcription factors whose rearrangements define certain distinctive tumors. For pseudomyogenic cholangioendothelioma, or PMH, which often looks like epithelioid sarcoma morphologically,
Right, tricky mimic.
very tricky.
Yeah.
FOSB nuclear expression is seen in over 95% of cases, typically due to SERPIN1 FOSB or ACTB FOSB fusions. Epithelioid hemangiomas can also show FOS rearrangement in about 30% of cases and FOSB rearrangement in 20%, with overall FOSB overexpression in approximately 50% of epithelioid hemangiomas. So FOSB is particularly useful for that PMH diagnosis.
And in bone?
In bone, FOS, and rarely FOSB, rearrangements are found in over 90% of osteomas and osteoblastomas. An anti-FOS antibody shows strong diffuse nuclear expression in over 80% of osteoblastomas and over 70% of osteoasomas, making it a very useful diagnostic tool for these benign bone tumors.
Okay. Any pitfalls there?
Yes, a significant pitfall to be aware of is the frequent nuclear expression of FOSB in normal endothelial cells and reactive myofibroblasts within granulation tissue or scar. So always confirm the staining is truly within the neoplastic cells and interpret it in the context of morphology, particularly watch out for reactive processes mimicking these tumors.
Let's discuss markers of osteoblastic differentiation, SATB2, osteocalcin, and osteonectin. How reliable are these for truly proving bone formation by IHC? Which one is best?
SATB2 is generally your best bet currently. It's a nuclear matrix-associated transcription factor that plays a crucial role in osteoblast lineage commitment. It's a very useful marker of osteoblastic differentiation, showing nuclear expression in primary benign or malignant bone-forming tumors. And in cases with heterologous osteoblastic differentiation, such as in carcinomas or MPNSTs that decide to form bone. It's also seen in some BCOR-rearranged round cell sarcomas and intestinal epithelium carcinomas, so like many markers, it's best interpreted in the panel.
What about osteocalcin and osteonectin? Less useful.
Generally less useful in routine practice. Osteocalcin is a predominant non-collagenous intraosseous protein localized to osteoblasts and reportedly specific for bone-forming cells. However, it's rarely used in clinical practice due to practical difficulties and the inferiority of older polyclonal antibodies. Its promise hasn't quite translated to routine utility. Osteonectin, a regulatory protein for osteoblast adhesion, is expressed in a wide range of cells, including fibroblasts, vascular parasites, and chondrocytes. Its use is limited due to cross-reactivity issues with available antisera. Even with monoclonal antibodies, it does not demonstrate the selectivity of expression seen with osteocalcin. So, for practical purposes, SATB2 is generally your most reliable IHC marker for confirming osteoblastic differentiation.
Now, a very specific confirmer for chordoma, brachyury. What makes this marker so definitive for this specific tumor type, arising from notochordal remnants? And how does it help us rule out the common mimics in the spine and skull base?
Brachyury is a transcription factor that regulates notochord-derived tissues and neoplasms, showing high levels in axial chordomas. Immunohistochemical staining for brachyury is a sensitive and specific marker of chordomas, with nearly 100% of cases demonstrating strong nuclear positivity.
Nearly 100%, wow.
Yes. This provides compelling molecular evidence of notochordal histogenesis, even when morphology is tricky or maybe less classic. It is crucially not expressed in chondrosarcoma, myoepithelioma, or various carcinomas that may mimic chordoma, most notably metastatic renal cell carcinoma. This clean negative in the differential makes it an incredibly powerful tool for chordoma.
What about poorly differentiated or de-differentiated chordoma? Does brachyury still work?
In poorly differentiated chordoma, which is an aggressive variant, keratin and brachyury expression are typically retained, but there is often loss of INI1, SRRCB1, which is another clue. De-differentiated chordoma, a very rare and aggressive form, usually loses brachyury and keratin expression as it transforms. This provides a progressive diagnostic picture as the tumor evolves towards more aggressive forms.
We're seeing a lot of these specific genomic-related markers. Tell us about the histone H3 mutations, specifically H3K36M and G34W for chondroblastoma and giant cell tumor of bone. These are truly revolutionary, aren't they? Turning specific genetic alterations into direct IHC stains we can use every day.
Absolutely revolutionary. These are incredibly specific IHC markers for common recurrent mutations, representing a significant leap in diagnostic precision for these specific bone tumors. For chondroblastoma, the most frequent mutation is at PHK36M of H33B, found in approximately 95% of cases.
95%.
Yes, the H3K36M IHC marker is extremely useful because it's seen in over 95% of chondroblastomas and is virtually absent in histologic mimics. The only described pitfall is rare expression due to a concurrent mutation and an occasional case of clear cell chondrosarcoma, but that's a very narrow exception. This marker has truly changed how we diagnose chondroblastoma.
And for giant cell tumor of bone, GCTB?
For giant cell tumor of bone, or GCTB, recurrent H33A mutations occur in approximately 95% of cases, with PG34W being the most common at about 90%. The H3G34W IHC marker is also extremely useful, showing nuclear expression in the neoplastic mononuclear cells of up to 90% of cases for both benign and malignant variants of GCTB.
Nuclear in the mononuclear cells.
Yes, that's key. It's very limited in histologic mimics, with expression in less than 3% of osteosarcomas, though these might actually represent malignant GCTB. It's important to note that these mutations are not present in giant cell tumor of soft tissue, making this a critical distinction that saves you from overcalling a benign soft tissue lesion as bone-related.
SMARCB1 or INI1, the lost marker of aggression. What makes its absence so diagnostically powerful?
It's counterintuitive, right? You're looking for something that isn't there.
It is counterintuitive, but immensely powerful. The SMARCB1 gene, located on 22q11, encodes a protein that is often deleted or mutated in certain aggressive tumors. What makes its loss so diagnostically powerful is that it results in the loss of nuclear expression of the protein, which becomes the diagnostic clue.
Okay.
This loss is observed in the majority of epithelioid sarcomas, over 90% of cases, as well as in malignant rhabdoid tumors, a subset of epithelioid MPNSTs up to 2/3, and some myoepithelial carcinomas. These are often aggressive tumors, and the loss of INI1 is a direct indicator of that underlying genetic event driving the tumor. How does it help in differentials?
It's incredibly important in distinguishing these entities from their mimics. For example, in the differential diagnosis between epithelioid hemangioendothelioma, EHE, and epithelioid sarcoma, EHE will show intact SESMAR-CB1 expression, while epithelioid sarcoma consistently demonstrates its loss. This is a very robust differential marker that can quickly narrow down a tough epithelioid spindle cell differential. It's a lifesaver sometimes.
And for liposarcomas, MDM2 and CDK4 are the dynamic duo that seems to pop up in almost every discussion about them. What's the science behind that, and how do we use them effectively?
They are indeed the classic pair for liposarcoma diagnosis. Overexpression of MDM2 and CDK4 is often due to amplification of the 12q13-14 region. This means a large segment of chromosome 12 containing these genes is copied multiple times, leading to abundant protein expression detectable by IHC.
Right, amplification again.
Yes. These markers are highly sensitive indicators for well-differentiated liposarcoma, or WDLPS, and dedifferentiated liposarcoma, or DDLPS. They are instrumental in differentiating these tumors from potential mimics such as sclerosing mesenteritis, retroperitoneal fibrosis, and leiomyosarcoma, where you typically won't see this amplification. Overexpression can be reliably confirmed by MDM2 FIH, as gene amplification is detected in over 95% of cases. So if you're suspecting WDLPS or DDLPS, particularly in the retroperitoneum or deep soft tissues, these are your absolute go-to markers.
Our final unique marker for today, H3K27Me3 and its implications for MPNST, another loss of expression marker, right? How does this one work, and where is it most useful?
You're right, another loss of expression marker, but with a different genetic basis. Loss of histone 3 lysine 27 trimethylation, or H3K27A3, is strongly associated with AZ12 and ED mutations in malignant peripheral nerve sheath tumors. These genes are part of the polycomb repressive complex 2, which helps regulate gene expression through histone modification. When these genes are mutated, the trimethylation mark on histone H3 at lysine 27 is lost, and that's what we detect as a loss of staining by IHC. This loss of staining is observed in approximately 50% of MPNSTs overall, ranging from 30% in low-grade tumors to about 90% in high-grade MPNSTs. It's a useful marker because its expression is generally retained in common mimics such as synovial sarcoma, fibrosarcomatous DFSP, and leiomyosarcoma.
So it helps rule those out.
Exactly. However, it's important to note that H3K27E3 is not lost in epithelioid MPNST, which often shows loss of INA1 instead. This highlights the importance of using these markers in a panel for the most accurate diagnosis, leveraging each marker's unique strengths in different contexts and tumor subtypes.
All right, we've covered a lot of ground on individual markers, from foundational to revolutionary. Now let's bring it all together in Section 6, high-yield differential diagnosis panels and practical applications. This is truly where the rubber meets the road for a new attending pathologist. Let's start with navigating spindle cell neoplasms, often one of the most common and challenging categories you encounter.
This is a critical area, absolutely, as spindle cell morphology is common across many entities and can be a real headache. Let's take solitary fibrous tumor, or SFT. You'd expect strong, often cytoplasmic CD34 positivity coupled with strong, diffuse nuclear STAT6 expression.
The STAT6 superstar.
Exactly. SFTs are typically negative for keratins S100, desmin, and CD31, though often show cytoplasmic CD99. The STAT6 positivity is that major point of overlap with dedifferentiated liposarcoma, so in that differential, you'd rely on MDM2 and CDK4 to confirm DDLPS. If you're looking at myxoid SFT versus low-grade fibromyxoid sarcoma, LGFMS, remember that LGFMS is CD34 negative and MUC4 positive, while SFT is consistently negative for MUC4. It's all about finding that unique combination in your panel.
What about monophasic synovial sarcoma? They can be notoriously tricky because they often lack that obvious epithelial component, just looking like a spindle cell sarcoma. How do we spot them with IHC?
Monophasic synovial sarcomas, or MSS, often show focal keratin reactivity and frequent EMA expression, which can be confusing, as we discussed. TLE1 nuclear staining is moderate to strong, but its specificity can be a concern, particularly now. Crucially, if you have access, the SS18-SSX fusion-specific antibody provides high sensitivity and specificity, serving as a definitive marker.
Right, the game changer.
Yes, MSS typically lacks CD34 and STAT6 expression, helping you differentiate from SFT. This is where the newest antibodies truly shine and can make the diagnosis much more straightforward.
And the often challenging malignant peripheral nerve sheath tumor, MPNST. It can mimic so many things, spindle cell sarcoma, melanoma.
For MPNST, S100 protein is variably positive, usually focal, and in about 30% to 50% of cases. SOX10 shows similar sensitivity to S100, but with better specificity against other mesenchymal mimics. Loss of H3K27Me3 is seen in approximately 50% of MPNSTs, with higher rates in high-grade tumors. If heterologous rhabdomyosarcomatous differentiation is present, you might see myogene positivity. Okay. To distinguish from MSS, remember that MSS will be positive for keratins, EMA, and the SS18-SSX specific antibody, which is unusual in MPNST. MPNST is also typically negative for STAT6 and MEC4, so again, the panel approach is key.
Finally, for spindle cell lipoma, a benign but important differential to keep in mind.
Spindle cell lipoma is typically strongly CD34 positive and rarely S100 positive. Loss of RB expression is a consistent finding, which can be quite helpful if you run it. Desmin positivity can occasionally be seen, reflecting the myofibroblastic component. This panel helps differentiate it from other CD34 positive spindle cell lesions like SFT or DFSP, especially in a subcutaneous location where spindle cell lipoma is common.
Moving on to deciphering epithelioid sarcomas and their mimics. This is another area where a well-chosen panel is key because these can be aggressive and look like so many other things, carcinoma, melanoma, other sarcomas.
Absolutely. It's a morphology fraught with peril. For epithelioid sarcoma, or EPS, a consistent finding is paranuclear keratin reactivity. Remember, those sarcomas surprised with keratin. CD34 is positive in about 50% of cases, and HHF35 in approximately 30%. Desmin and S100 protein are almost always negative in conventional EPS, though desmin may be seen in the proximal type. The diagnostic hallmark for EPS is the loss of nuclear SMRCB1, INI1 expression, in over 90% of cases. If you see epithelioid cells with keratin positivity and loss of IMA1, you are almost certainly looking at epithelioid sarcoma. This is a very strong and reliable indicator.
How do we differentiate that from epithelioid angiosarcoma, EAS, or epithelioid hemangioepithelioma, EHE? They also have an epithelioid look and can express keratin, making it confusing.
That's the classic challenge. In EE and EA, keratin expression is not uncommon, and EE can also express keratins. EMA, however, is limited in EES. The key for proving true endothelial differentiation in these vascular tumors is strong expression of CD31 and, even more reliably, ERG.
ERG again.
Yes. CD34 is positive in both EC and EPS, so it's not discriminatory in this particular differential. The critical differentiator here is that EAS and EE consistently show intact SMARCB1 expression, while EPS demonstrates its loss. This is your primary way out of that diagnostic dilemma in I1 status.
What about distinguishing these from metastatic carcinoma or melanoma, which are always in the back of your mind with any epithelioid lesion, right?
Always. For metastatic carcinoma, you'll rely on diffuse keratin and IMA positivity, maybe PX8 for renal, etc. For melanoma, use S100, SOX10, HMB45, melon A, and maybe tyrosinase. When differentiating EPS from melanoma, remember that S100 and SOX10 are typically negative in EPS, and crucially, SMRCB1 expression is lost in EPS but retained in melanoma. This provides a clear distinction. Always use a broad panel to cover all your bases here when you see epithelioid morphology.
All right, now for a masterclass in panels, unraveling small round cell tumors. This is often one of the toughest areas for pathologists because morphologically they can be almost indistinguishable without the right IHC panel. They just look blue.
It truly is. They all look blue and round. These tumors can look deceptively similar, demanding a precise IHC approach to avoid misdiagnosis. For Ewing sarcoma, or ES, you'll typically see diffuse membranous CD99 expression. It's also usually positive for FLI1, though not specific, and nuclear NKX22, which is becoming more important.
NKX22.
Keratin can be positive in 20% to 30% of cases, usually in a focal pattern. Remember our keratin pitfalls. ES is typically negative for chromogranin, GFAP, desmin, muscle-specific actin, myogenin, CD31, and CD45.
How do you approach rhabdomyosarcoma, or RMS, in this context? What are the key markers there?
For RMS, regardless of subtype, embryonal, alveolar, pleomorphic, epithelioid, the highly specific nuclear transcription factors myogenin and MYOD1 are key, along with desmin, which follows a cumulative and consistent sequence reflecting myogenesis. HHF35 is also useful. Myoglobin is less sensitive as it appears later in maturation. Alveolar RMS, or ARMS, shows more extensive myogenin and MYOD1 than embryonal RMS usually. Importantly, desmoplastic small round cell tumor, or DSRCT, is desmin positive but myogenin negative, a crucial distinction between those two desmin positive round cell tumors.
Speaking of DSRCT, what's its unique, almost bizarre immunoprofile? You mentioned polyphenotypic earlier.
DSRCT, characterized by the EWSR1-WT1 chimeric transcript, has an unusual polyphenotypic immunoprofile, meaning it expresses markers from multiple lineages, making it truly unique. It frequently stains for keratin, 86%, EMA, 93%, NSC, 81%, vimentin, 97%, and desmin, 90%.
Wow, all of those.
Yes. CD99 reactivity is uncommon. WT1, specifically with a polyclonal antibody against the C-terminus, is frequently positive. Actin, myogenin, MYOD1, and chromogranin are generally absent. This unique combination, especially the triple expression of epithelial, keratinema, mesenchymal, vimentin, and sometimes neural markers, NSE, is almost diagnostic when you see it.
And for neuroblastoma and lymphoma, which can also present as small round cell tumors, how do we pick those up?
Neuroblastoma typically expresses NSC, synaptophysin, chromogranin, NFP, and NB84 with over 95% positivity. It's typically CD99 negative, and nuclear PHOX2B is a very useful diagnostic marker now.
PHOX2B.
Yes. For lymphoma, especially lymphoblastic lymphoma, CD45 is virtually ubiquitous and highly specific, and the monoclonal antibody cocktail PD726 plus 2B11 is very effective in paraffin sections. CD99 commonly labels lymphoblastic lymphoma, which is a pitfall when thinking about Ewing, but TDT is often positive in the lymphoblastic lymphoma. Lymphomas generally lack markers of other lineages, muscle, epithelial, neural, providing a clear distinction.
What about mesenchymal chondrosarcoma, or MCS, another tricky one that can look very much like Ewing, with small blue cells?
MCS can be challenging as its small cell component expresses CD99 and NKX22, creating an overlap with ES. However, its cartilaginous component, if present, is S100 positive. Unlike ES, MCS is non-reactive for synaptophysin and typically lacks desmin, actin, keratin, or EMA. It lacks the EWSR1 rearrangement found in ES, instead characterized by a HEY1 and COA2 fusion. So while CD99 points you to a round cell tumor, the specific panel, S100 and cartilage, lack of other markers, and molecular features diverge.
And the newer round cell sarcomas with specific gene fusions, like CIC DUX4 rearranged sarcoma and BCOR fusion alteration sarcoma. These are becoming increasingly important to recognize. What are the IHC clues?
For CSE DUX4 rearranged sarcomas, CD99 expression is generally multifocal, so not as diffuse as ES. You'll find overexpression of ETV4, with over 90% showing moderate to strong nuclear expression, and WT1 over 95% nuclear with an N-terminus antibody. DUX4, a diffuse nuclear marker, is also promising. Given variable sensitivities, a panel combining CD99, WT1, ETV4, and/or DUX4 is more reliable.
Okay.
For BCR fusion salturation sarcomas, nuclear BCOR is sensitive but not specific. CCNB3, with over 95% expression, is a useful and specific marker. SATB2 and TLE1 expression are common, and NTRK3 upregulation, which can be detected by pan-Trk IHC, may also occur. These are the newer entities where IHC helps identify the likely underlying fusions, making them critical for accurate classification and sometimes therapy.
This is truly a comprehensive guide to navigating these complex panels. Let's tackle specific bone tumor markers and their mimics briefly. Starting with chordoma, that midline villain we mentioned with brachyury.
Right. Chordoma, a malignant tumor with notochord-like differentiation, primarily occurs in the axial skeleton. Histologically, it's characterized by cords and sheets of tumor cells in a myxoid stroma, often with those classic physioliferous cells. Its immunoprofile includes keratin, EMA, S100 protein 60–80%, and most importantly, brachyury, which is sensitive and specific, positive in nearly 100% of cases with strong nuclear staining. Brachyury is your definitive confirmation.
And how do you differentiate chordoma from its challenging mimics, again, like metastatic carcinoma or chondrosarcoma, using that?
In the differential, consider metastatic renal cell carcinoma, which will be PAX8 positive but brachyury negative. Chondrosarcoma is S100 positive that lacks epithelial markers and brachyury. Myoepithelial tumors will be keratin, S100, and maybe GFE positive but lack brachyury. Myxopapillary ependymoma is GFE positive but also lacks brachyury. This panel, centered on brachyury, is critical for accurate diagnosis, ruling out what can be very convincing lookalikes, especially on small biopsies.
What about chondroblastoma, another one with a very specific, almost unique IHC signature now?
Chondroblastoma, a cartilaginous tumor typically arising in the epices of long bones in younger patients, is almost always positive for the H3K36M mutation by IHC, with nuclear expression in over 95% of cases. It's also S100 protein positive in over 90% of cases. The H3K36M marker is your definitive confirmation and has truly revolutionized its diagnosis, making it much easier than it used to be.
And giant cell tumor of bone, another where those new H3 mutations are so critical.
Giant cell tumor of bone, or GCTB, is characterized by recurrent H3–3A mutations, most commonly PG34W, which can be detected by IHC. Nuclear expression of H3G34W is present in the neoplastic mononuclear cells of up to 90% of cases for both benign and malignant GCTB.
Right, the mononuclear cells, not the giant cells.
Exactly. While the osteoclast-like giant cells stain strongly for CD68, the neoplastic mononuclear cells are often weaker or negative. Stromal cells may express IDSMA, but they lack CD45, S100 protein, desmin, and lysozyme. This combination, particularly the H3G34W positivity in the mononuclear cells, is highly specific and helps distinguish it from giant cell tumor of soft tissue, which lacks this key mutation.
This has been an incredibly deep dive into the practical world of soft tissue and bone tumor IHC. Just fantastic. To wrap this up, what are your essential high-yield sign-em-out pools for our new attending pathologists as they step into independent practice? What are the key takeaways you want them to etch into their minds as they face these cases?
Okay, pearls. The first and most crucial pearl is the power of a well-designed panel. Don't just throw every stain at a case like spaghetti on a wall hoping something sticks.
Right.
Thoughtfully select markers based on the morphology you see in the clinical context. This focused approach helps confirm or exclude specific lineages efficiently and accurately, rather than generating confusing, ambiguous results. It's about precision, not quantity.
And what about quality control for your stains? How do we ensure we're not misinterpreting an artifact or a bad run?
Always assess your internal controls. Look for expected reactivity in non-neoplastic elements within the same section. For example, vimentin in endothelial cells or ERG in normal endothelium. This ensures proper tissue preservation and confirms that your assay performed as expected, which is foundational to trusting any result on your slide. If your controls aren't working, your tumor stones might not be either, or you simply can't rely on them.
We talked a lot about aberrant staining and pitfalls today. How do we apply that practically at the scope? How do we stay vigilant?
Be acutely aware of aberrant staining patterns. Understanding common patterns, like keratin expression in certain sarcomas, is just as important as knowing the classic positive reactions. Recognize technical pitfalls, such as overly sensitive detection methods or edge artifact, that can lead to spurious positivity. If a stain doesn't fit the morphological picture, question it. Don't force the fit. Biology is often more logical than an artifact. Step back and rethink.
Connecting the dots seems like a theme throughout our discussion. How crucial is that for confident sign-out, integrating everything?
It is absolutely crucial. Always emphasize connecting your IHC findings with the clinical history, imaging results, and most importantly, the underlying H&E morphology. If your immunohistochemical profile doesn't fit with the overall clinical pathologic picture, reevaluate. It could indicate a misinterpretation, a rare variant, a technical issue, or even sampling error. Don't simply read the IHC result in isolation. Integrate it into the entire patient story.
And finally, with the increasing role of genomics, when should a pathologist consider molecular studies, and how does IHC guide that decision? When do we pull that trigger?
IHC can and should guide the data for molecular confirmation, particularly with fusion-driven sarcomas where IHC surrogates exist but aren't 100% definitive or specific. For instance, in Ewing sarcoma, maybe checking UWSR1, synovial sarcoma, SS18-SSX, inflammatory myofibroblastic tumor, Alacros 1 ret, solitary fibrous tumor, STAT6 is usually enough, but maybe NAB2 STAT6 fish if needed, and low-grade fibromyxoid sarcomasclerosing epithelioid fibrosarcoma, MUC4 is great, but FUSH confirms. Strong IHC indicators should prompt molecular studies like FISH or RNA sequencing to confirm the characteristic gene fusions. This ensures the highest level of diagnostic accuracy and increasingly guides precise therapeutic decisions like with NTRK fusions. IHC is often the first best screen, but molecular is the ultimate confirmation for many of these specific entities.
This has been an incredibly insightful deep dive. Today, we really drill down into the immunohistochemical landscape of soft tissue and bone tumors, aiming to arm you, our listener, with the precision tools you need for confident sign-out. We've navigated the complexities of intermediate filaments, explored nuanced epithelial and muscle markers, pinpointed nerve sheath and endothelial differentiators, and delved into the powerful insights offered by genomic-driven markers. A field that's constantly evolving, that's for sure.
It truly is a dynamic and challenging field. Your mastery of IHC isn't just about memorizing markers and patterns, it's really about understanding the biological narratives they tell. It's about seeing beyond the stain to the underlying cellular processes and genetic drivers. As you step into this independent role, remember that every slide is a puzzle, and these stains are crucial pieces, but only when interpreted thoughtfully and holistically, integrating everything.
So, what other diagnostic challenges might these aha moments in IHD help you unravel tomorrow? Perhaps a soft tissue tumor that defies easy categorization, or a bone lesion that looks like one thing but is actually another, revealed with the help of a single precise nuclear stain like brachyury or H3G34W. Thank you for joining us on this deep dive into what it takes to be truly well-informed in this demanding but incredibly rewarding field. We wish you all the best in your independent practice.